This is the recording for Chapter 32, Issues Related to Human Sexuality and Gender Dysphoria. So, sexuality is a basic human need and an intimate part of the total personality. It influences our thoughts, actions, and interactions and is involved in aspects of physical and mental health. This is the totality of the person and does not exclusively relate to sexual organs or sexual behavior. Society's attitude toward sexuality is changing, and clients are becoming more open to seeking assistance in sexual matters. Nurses are not sex therapists unless they have special training and advanced degrees, but they can readily give information in the people they care for on prevention, therapeutics, and educational issues. So, gender dysphoria, it's a person's sense of being male or female. It is awareness of one's masculinity or femininity, or of being other gendered, neither male nor female, or both male and female. We use the term cisgender to refer to a person who identifies as the same biological sex that they were assigned at birth. Transgender refers to a state in which the individual experiences an issue with their assigned sex and their biological identity and their gender identity. We all have a biological, that is a genetic gender identity. We also have the gender identity that we feel comfortable with. And so we have more than one aspect of our sexuality. Transgender is what we use to identify someone. In other words, um, cisgender and transgender individuals may be attracted to their own gender or another gender. Being attracted to someone of the same sex used to be considered a diagnosis in the old DSM-5. It is no longer in that. Gender dysphoria is that diagnosis that ended up in the DSM-5. And what the criteria is, in addition to feeling like the assigned sex and the expressed gender do not mesh, the client must experience distress in school, social, occupational, and performance issues for at least 6 months. It's not sufficient to make a diagnosis solely on parents or other people's discomfort with someone's gender identity. Changes in labeling and criteria for diagnosis reflect efforts within the psychiatric community to depathologize variances in gender. There's increased agreement among the psychiatric community that being transgender is not an illness and it's not something that can be cured. However, when they have issues with difficulties or struggles from gender identity, treatment may be very beneficial. There was controversy about whether gender dysphoria should be included in the DSM-5. The transgender community protested to the work group that it is different and is not a disease process. So the DSM-5 work group attempted to address some of those concerns of the transgender community taking into consideration the stigma associated with inclusion of the diagnosis, but also need for inclusion of terms to adequately treat and care. If this diagnosis was not included, those who might seek to choose um, psychiatric care or medical surgical care might be denied insurance coverage because it would not be a diagnosis. So the term gender dysphoria was adopted to minimize the stigma that the transgender label may place on someone. So the DSM-5 looks at gender dysphoria in two groups, in children and in adolescents and adult. The major focus is on the condition as it emerges in childhood. Nurses who work in primary care with children may have the greatest um, effect in responding to the needs of this population. Statistics about prevalence vary, but in most countries they reveal a greater percentage of males than females who identify as transgender. Some individuals choose to find ways of living with their gender without altering their bodies. Others have a strong desire to change their physical body to reflect their core gender identity. It has been noted that transgender ideation and expression sometimes dissipate after early childhood. However, if it persists into adolescence, it appears to be an established identity of that person. So, predisposing factors to gender dysphoria. The etiology is really unknown. Um, there are some models that suggest that it is biological, along with prenatal androgen exposure, but no genetics or neuroanatomical findings have been identified for a single cause. There is recent suggestions that possibly there is a genetic link, but that has not been decided if that actually is a factor or not. So, gender roles are culturally defined, and parents would encourage either masculine or feminine behaviors in their offspring. However, environment may also play a role in gender expression. There's no data to suggest that there is a one explanation for the development of gender identity. Parents may present with anxiety about their child's gender nonconforming behavior based on their attitudes and perceptions. Likewise, children may present with symptoms of anxiety and depression related to negative attitudes toward their gender nonconforming behaviors. Interestingly enough, small children who show gender nonconforming behavior many times do not grow up to be transgender, and maybe many people who identified themselves as transgender as an adult were not identified as gender nonconforming in childhood. Some children may resist wearing clothing or playing with toys that are typical for their assigned sex. This is normal childhood behavior. When these behaviors persist into later childhood and adolescence, they may indicate a stable gender identity. Gender dysphoria is not diagnosed unless the symptoms of distress emerge, and marked distress, such as depression related to one's desire to be the opposite gender, disgust with one's own genital, or fear and anxiety related to others' knowledge of their differing gender identity. These children may be subjected to bullying, rejected by peers, and disapproved by family members. This rejection occurs early in childhood for boys, but often does not occur before adolescence because masculine behavior in girls is more culturally accepted than feminine behavior in boys. In face of this rejection, interpersonal relationships between family, friends, peer groups, and others may be damaged. So this is kind of just some more of from the last slide. Um, we do need to, parents may, this is something in education, may be concerned because their son wants to play with dolls or their daughter is more interested in playing with trucks than she is with dolls. And in small children, that is very normal. Does not mean there's anything wrong with their gender, but parents who are concerned about that may be very anxious about their behavior of their child. So when we're looking at a child with gender dysphoria, ineffective coping, impaired social interaction, and low self-esteem are issues that may need to be addressed. Um, Goals in treating this child um, includes verbalizing knowledge of appropriate behaviors, expressing personal satisfaction and comfortability with their self-concept and gender identity, and promoting self-esteem. Interventions include educating parents about issues that the child may face, allowing the child to describe their perception of problems, offering support, and encouraging activities in which the child is likely to succeed. So identification of whether there is truly a gender dysphoria in a child should be done very cautiously because there are very gender related behaviors that vary in this age group. Um, when the issue is identified as a real gender dysphoria, then treatment should include evaluation and management of concurrent mental health issues, social support systems, and later in childhood, um, non judgmental exploration of the individual's desire to sex reassignment. Type of treatment for gender dysphoria may be no treatment at all. It's an individual, it's a matter of personal choice. However, if issues associated with mental health concerns, such as depression, anxiety, social isolation, parental conflict, low self esteem, anger, these things must be addressed. Um, Children who are gender nonconforming are often targets of bullying and violence, especially males. Nurses can play a role in educating families and providing support to identify safe, supportive peer groups for these children. So, with adolescents and adults with gender dysphoria, with this condition, an individual, despite having anatomical characteristics of a given gender, has the self perception of being the opposite gender. Individuals with this disorder may not feel comfortable wearing clothes of their assigned gender and often engage in dressing as their desired gender. Um, they may request healthcare system to provide hormonal or surgical um, treatment for their issues. Depression and anxiety are common and often attributed to the fact that the individual is not able to live in their desired gender role. Seeking treatment is very necessary. Um, Their evidence is that the longer people live with gender dysphoria before seeking treatment, the greater likelihood of suicide attempts and completions, with a 41% lifetime prevalence of suicide attempts among transgender individuals, and 33% of those identified that postponed preventative care because of discrimination or disrespect from their healthcare providers. Adolescents rarely have the desire or motivation to alter their cross-gender roles, and in the interest of patient-centered cares, nurses should listen carefully as they talk about their desires and their treatment preferences. Some adults seek therapy to learn how to cope with their sexual identity, while others may have direct and immediately requests for hormonal therapy and surgical sex reassignment. Nursing care of the post-gender reassignment surgical patient is similar to other post-surgical patients. Um, Comfort, preventing infection, integrity of the surgical site, meeting um, the basic needs for elimination, nutrition, rest. Um, Psychosocial needs may have to do with body images and fears and insecurities about relating to others and being accepted in a new gender role. Um, Nurses can meet these needs by a non-threatening, non-judgment healing atmosphere. So a little bit about the paraphilic disorders. Paraphilia is a DSM-5 diagnosis that is defined as any intense and persistent sexual interest other than sexual interest in genital stimulation or preparatory fondling with phenotypical, normal, physically mature, consenting human partners. That's kind of a mouthful there. Um, so the paraphilic diseases, and I think the next slide has some list of them. Um, they are only labeled as a paraphilic disorder when these fantasies or behaviors occur over a period of at least 6 months, cause the client significant distress in or impairment in their social life, their occupational, or other um, areas of functioning. Some of these paraphilic behaviors are illegal sex acts, and consequently, the individual may come to the attention of legal authorities before being introduced to psychiatric treatment. There is very limited data on the prevalence or course of paraphilic disorders. Um, Most of the information has been obtained from studies of incarcerated sex offenders. Other sources of information have been outpatient psychiatric services for individuals outside of criminal justice. Um, Data suggests that most people who seek treatment do for pedophilic disorder, voyeuristic disorder, or exhibitionist disorder. More individuals are men, and 80% of these behaviors begin before the age of 18. Behaviors tend to decline with age. And in adults older than 50, the occurrence of criminal acts is low, except for those behaviors that occur in isolation or in a cooperative partner. It's common for individuals who have one paraphilia to actually have multiple. And here is the list that I was talking about, and I suggest that you kind of take a look at these and make sure that you know what each kind is. Um, like like I said, many of these are criminal acts, and so um, may not be something that anyone is going to come forward and talk about. Um, Pedophiles are the ones that we most often see because they are incarcerated and are subject to treatment to attempt to help them with this problem when they are incarcerated. So, predisposing factors for the paraphilic disorders. Again, like many things in mental health, exact cause is unknown, but studies have identified some biological abnormalities in individuals, abnormal hormone levels, chromosomal abnormalities have been implicated in some studies. Reports that serotonin agents have been effective in decreasing paraphilic arousal and provides support for the hormone related hypothesis. Um, Neuroimaging of sex offenders have demonstrated that congenital or acquired brain damage are overrepresented in this population. Temporal lobe diseases such as psychomotor seizures or temporal lobe tumors have been implicated in some individuals. Abnormal level of androgens may also contribute. Um, but since the majority of these studies involved people who were violent sex offenders, it's really hard to generalize any specifics from the research. There is a psychoanalytic approach that defines an individual with paraphilic disorder as one who has not completed the normal development process toward heterosexual adjustment. Um, Another psychoanalytic model says that paraphilias may arise from unresolved hostility secondary to child physical, emotional, or sexual trauma themselves. And then there's a behavioral model that their hypothesis is whether or not the individual engages in this behavior depends on the type of reinforcement that the individual receives following the behavior. The initial act may be committed for various reasons. Some examples include recalling memories of experiences from early life, modeling behaviors of others, uh, mimicking things they have seen in the media, or recalling past traumas that were acted on themselves. Once the initial act has been committed, the individual with a paraphilic disorder evaluates the behavior and decides whether to repeat it or not. Fear of punishment or perceived harm or injury to the victim or a lack of pleasure derived from the experience may extinguish the behavior. However, when there are not negative consequences, when the act is highly pleasurable or the person immediately escapes and thereby avoids seeing any negative consequences experienced by the victim, the activity is more likely to be repeated. Biological treatment of individuals with paraphilic disorders has been focused on blocking or decreasing the level of circulating androgens. Um, the most extensively used medicines for this are progesterone derivatives that block testosterone synthesis or block the androgen receptors. They do not influence the direction of sexual drive toward appropriate adult partners. Instead, they act to decrease the libido by reducing serum testosterone levels to subnormal concentrations. They are not meant to be the sole source of treatment, and they work best when they are given in conjunction with participation in individual or group therapy. The psychoanalytic approaches that have been tried in treatment of paraphilic disorders. In this type of therapy, the therapist helps the client to identify unresolved traumas from conflicts from early childhood. The therapy focuses on helping the individual resolve these early conflicts, then relieving the anxiety that prevented them from forming appropriate relationships. Um, then the individual would have no further need for paraphilic fantasy. So, analysis research has identified cognitive behavioral therapy as the most effective in reducing repeat sex offending acts, and it's currently the most evidence based treatment for sex offenders. Intervention includes social skills training, cognitive restructuring, and an effort to change the individual's maladaptive behaviors. Once behavioral approaches to decreasing inappropriate sexual arousal have included image desensitization, um, and imageal desensitization, the client learns how to achieve a state of relaxation while recalling situations that triggered the behavior, and with the idea that relaxation will lead to less impulsivity in one's behavior. The role of the nurse in treating paraphilic disorders, um, they may deny that they have a problem. Focus should be to diagnose and treat the problem as early as possible to minimize difficulties. Um, One of your roles as a nurse may include conducting a sexual history to identify the presence of these disorders. So, client and patient education for clients with sexual disorders. The topic for discussion with the client and the family should include nature of the illness, including the causes of dysfunction and or disorders, symptoms of paraphilic disorders and sexual dysfunctions, management of the illness, including practices and ways of sexual expression, effects of medication and alcohol, and support services, which include referrals to sex therapists. So, many of the things that we teach clients is not about sexual disorders. We do teach about normal growth and development, what people can expect. We answer questions that we are capable of answering, referring to someone if there are more questions that we are not capable of answering, and then doing education. And most of the education that the bedside nurse will do is not going to be about treatment of sexual disorders. It's going to be about um, taking care of yourself as a man or a woman, um, teaching health habits. Um, when we give medications for depression, the SSRIs, we need to tell people that these medications may cause a change in sexual function, and let them know that if that happens, they should notify their provider. And there are other medications that may not have those side effects for those. We want to talk about substance abuse and sexually transmitted diseases. As a Catholic hospital, you will not see anyone at OSF doing sexual reassignment surgeries, and you may not see anyone even getting treatment at an OSF facility. But we do see these people, and we do treat everyone with care, no matter what their beliefs are, no matter what their history is. Um, Even if they're a criminal, we still treat them with dignity and care because they are a person. And that's kind of the modus operandi of the Catholic Church. We're not going to support behaviors, but we support the person.